Hi, Dr. Trina. How you doing today?
Hey, Dr. Wendy, how are you? Thank you for
I'm
having me.
Yeah, thanks for being here. Welcome to the Collaborative Cancer Care platform. I'm really excited to have you here as an expert in colorectal and lung cancer screening, which is two important topics for our audience. So, why don't we start off by you first, just introducing yourself?
Okay, well, I'm Dr. Trina Turner. I am a board certified registered nurse. I have been a nurse for 30 years. I've been in oncology for about 6 years now, and I do nurse navigation. So for me, it is important that I work on the beginning end of the spectrum, which is prevention, early detection. So my wheelhouse is lung, colorectal, and tobacco cessation. So I go out in the community and I talk about the importance of early detection, lung screenings, colonoscopies. Also about tobacco cessation, I went and I became a face-to-face coach, cessation coach, they call it, with our Delaware Quit Line here in Delaware. And then I also became a tobacco treatment specialist certified through Mayo Clinic. So that's what I've been doing now for about the last 6 years, and I actually love what I do.
That's amazing. So you were kind of on the end of primary and secondary prevention. That education is so key.
Mhm.
And tell us what you did to kind of, develop that. So being a nurse navigator, when I think of a nurse navigator as an oncology nurse practitioner, I think of someone that helps patients who are already diagnosed with cancer kind of navigate the system. So how did you go from that to really going out into the community to educate people about colorectal and lung cancer screenings?
So when I applied for the position, I thought I was going to be a navigator that would be seeing patients in the hospital setting. You know, once they see the oncologist, they get the initial diagnosis, and then they have a navigator that guides them through the process. When I interviewed, though, I was told that this was a new position they were going to be developing and building, which I was excited about because I was able to get in on the ground up. And they wanted it to primarily be about early detection and prevention, and primarily on lung and colorectal. So when I started the position, I helped them develop a lung screening dashboard, and it was through the Epic software system. And I would follow the patients that would get lung screenings. So the way the lung screening program works is as long as you have a certain amount of tobacco years, as long as you are asymptomatic, as long as depending on how much you smoke, a pack a day or 2 packs a day for 20 years or 10 years, depending. And you were asymptomatic, you had no symptoms at all, no pain, no coughing, no anything, you could go into this program and you would get a low dose CT, which is no IV dye. It's a very minimum dose of radon, and they would look to see if you had any lung nodules or anything that looked abnormal. As long as everything looked good, you would come back in a year and you would continue to get these screenings just to follow and make sure that nothing's going on with you. So when we started this program, I followed all the patients that had to get very close up screenings. Like after 3 months, they needed to get another CAT scan, or they needed to get a PET scan, or a biopsy, or something that because something looked abnormal. So I was in charge of those patients. So this program wasn't there when I got there, and I actually helped them develop it. And also, we did the colorectal side, making sure that the patients were able to get their colonoscopies if they needed referrals to GI specialists, if they needed to get Cologuard or FIT or whatever the doctor and the patient decided what their best screening tool was going to be. I helped facilitate that too.
Yeah, that's amazing. I think every oncology clinic organization should have an arm where we're looking at prevention because we do
Absolutely.
a great job of treating, right? Diagnosis and treating. But I think that primary and secondary prevention is definitely key. And I commend your organization for doing that, even, hiring you into the position to specifically focus on prevention. So
Absolutely.
these individuals who you were interacting with, or your patients who were part of this dashboard, part of this program, they didn't have cancer. They were just being
Yeah,
screened
yeah. They
for
were being
cancer.
screened. Yes. Mhm.
Okay. And can you tell us why that's important? Like, why is it important, especially colorectal cancers on the
Mhm.
rise in our younger populations? We're seeing a
Yeah.
lot of young people between the ages of 30, 40, and even 50 being
Mhm.
diagnosed with colon cancer. So tell us why this is important.
Screening is so important because if we can catch it early, your prognosis is so much better. And if we have to do a treatment, the treatment will be less invasive. It could be less I don't want to say corrosive, but more less toxic to you. There are patients that had lung screenings, for instance, and let's say that they found a small nodule, they did a biopsy, they found out that it was lung cancer. Well, we caught it at such an early stage that they might just have a small surgical procedure and they don't need radiation or chemotherapy. And the same way goes with colorectal screening. A lot of I was so glad that they dropped the age down to 45 because it used to be 50 when you could start screening, and now it's 45. And honestly, we're advocating in Congress to try to get it pushed to 40 because we're seeing so many people who are getting colorectal cancer diagnosis at such an early age. So if we can catch it early, the treatment is less toxic to you. You have a better outcome. If you stop smoking, that's very important because smoking triggers all types of cancers.
Oh, yeah.
If we could get them to stop smoking, if we can get them to do their colorectal treatments, a lot of patients, colorectal screenings, a lot of patients are very hesitant about getting that colonoscopy. And, we had to talk to them about, I understand you're worried about it. The prep is probably the worst thing of it all, honestly.
Yes.
And the prep has actually gotten better over years. But if we can do this screening and catch it early, then your outcomes are going to be so much better.
Yeah, absolutely. But I think like the general public, we don't think about that, right? As we're living our day-to-day life, we're not thinking about, colonoscopies. We're not thinking about lung cancer, especially if we're smokers, because smoking has become a normal part of our society. It's a
Mhm.
habit that many people have, and we
Mhm.
don't think too much about it. So if you can speak to someone when you're out in the community, how do you talk to them about um, not really convincing, but educating them on colorectal screening? What would you say to them? And I'm only asking that because as people are watching, they may want to have a conversation with, their family member who may be over 45 or who may be having symptoms that need to be assessed so they can actually get a screening.
So I can tell you, I have a personal story. I have a patient that I met probably my first year out of going into the community and talking about colorectal screenings. And it was a young lady. She was like 40, 42. And at that time, the age limit hadn't been dropped yet. It was still 50. And she didn't have a history that she knew of. So family history is very important. You need to know what's going on in your family. And we were just talking, and she was saying, I've been having this GI upset. It comes and it goes. I think it's just stress, or, I have a lot of life changes that are going on. So we just started talking, and she was having, heartburn, and she was having diarrhea at times, and, pain. And she wasn't seeing blood on her stools, but she was having the symptoms that were a little worrisome. So I told her, your best bet is to really go and talk to your primary care doctor. I said, just let them know what's going on. So she ended up calling me, I want to say 3 or 4 months later, and she had talked to her primary care doctor. She talked to her parents and found out that they had colorectal cancer in her great grandmother on her father's side, her great grandmother on her mother's side, and her grandmother on her father's side had colorectal cancer. So, because she had that family history, automatically she was able to get screened. And normally, what they'll do is they want to know the age of diagnosis for your whoever your family is, so that way they can start 10 years early. So her grandmother was diagnosed at 55. So she technically could start right now getting screens, and that's what she did. She ended up getting a screen, and she had stage 1 colorectal cancer. She was able to get a small um, surgery where they only removed a small portion of her colon, and she didn't have to have. And as they would say, the margins are clear. So that means when the doctors take the piece of cancer out, as long as the margins are clear and everything looks good, they will say, okay, we got everything we need. It was very small. It was only maybe a couple, maybe like a centimeter or two in diameter, and she didn't have to have chemotherapy or radiation. She just had to go now yearly for cancer screening. So every year she would get a colonoscopy, and she is now 5 years out, and they're saying, okay, this everything looks good. I'm going to take you to every 2 years now. And we caught it early, and that was just a normal conversation we were having in the community. She had a little bit of heartburn, a little bit of stomach upset. She thought it was, just basically stress or diet, something she was eating. But once she delved into her family history, which is so important, she found out that, there is a history of colorectal cancer in her family. So, it's so important to know your history. It's so important.
Oh my God, there are so many gems in that
Oh
story.
my goodness.
First and foremost is knowing your body,
Absolutely.
knowing when something is off.
Exactly.
So that's the key. The first key is if something is off, do not let it go.
Exactly.
Second is making sure you're going to your primary care doctor and advocating for yourself, because
Absolutely.
you could have went to that primary care doctor and they're like, whatever, it is stress, it is heartburn, and kind of send her on her way. But,
Mhm.
knowing your body, advocating for yourself to say, I need this checked out, I need you to do more. And third, which is a big hitter, is talking to your family.
Mm.
What is your family history? And not waiting until you're having symptoms or something's going wrong, but have that conversation today.
Mhm.
Figure out what is your family history, even if it's cancer, diabetes, high blood pressure, heart disease, you want to know. So, oh my goodness, I love that story. And that really hits home for both,
It
for
is. And
colon
she
and
had
lung.
genetic testing done. So that was so important too. Because, luckily she didn't have Lynch syndrome, which is like a
Yep.
real big genetic predisposition or factor within colorectal cancer. She didn't have that, but she has children. So now she's very, very proactive about it and making sure that she's tested, down the line. Once her children get a certain age, they'll get tested. Her family, her grandmother went and got tested. Her mother went and got tested. Her father went and got tested. So it's just been such a learning journey for them. And it made them so much aware of how they have to really, really take care of themselves and know your history and know your body. Pay attention. Pay attention.
Absolutely, absolutely. I love that. And what about our society members who are smokers, who've been
Mhm.
smoking for years, and they feel fine, and
Mhm.
smoking, it's an addiction,
It's an
right? It
addiction.
definitely is an addiction. So I would love for you to one talk about not only the screening but the smoking censation. How does that work? Because I don't think a lot of people are aware that there are programs specifically out there to
Mhm.
help people to stop smoking, and
Exactly.
statewide. It doesn't
Mhm.
matter what state you're in, they definitely support this and have these programs. So talk to us a little bit about that program.
So for the tobacco cessation program that I kind of instituted and run, I am a partner with the Delaware Quit Line. So there are different ways that you can become enrolled into the Quit Line. You can have a face-to-face cessation coach, which is me. You would see me. We would talk about and discuss how long you've been smoking, the triggers that you have, the different types of things you might have tried in the past, reasons for why you smoke or don't want to quit, and then I get them enrolled into the quit line. I talk to their primary care provider, and we decide what would be best for them, whether or not it's a patch, whether or not it may be the gum. They have a nasal spray. It could be medication. Because I've had some patients that have tried the patches in the past, and they're like, "Oh, it didn't work for me. I don't really want to try that. Let's try something different." And now we're finding, as we're doing research, that sometimes you have to do a one-two combination. I'll have patients that are taking the patches, but I also will tell them, when you feel as though you just have this trigger and you're stressed or you need something extra, let's do the lozenge or let's do gum, add it on. And we found that that's become effective. It's free of charge for the patients. They don't pay for anything. What they do is they get enrolled. They will get the nicotine replacement product, and normally either the quit line or a coach will follow them to see whether or not this is working, because they could be on it for about 2 to 3 weeks and they'll say, you know what, Trina, this isn't really working for me. Can we try something different? And we will continue to pay and get them into the program. They don't have to pay anything out of pocket. We just only pay for one product at a time. So we want them to at least have 2 to 3 weeks on one product just to, get into your system to try to get your mindset that you're ready to quit. And then if it's not working, okay, let's pivot and try something different. It's been probably about 5 years since I've been in the program, and I've been able to help a lot of patients. And I've had patients that have come back. They fell off the wagon. They come back and they say, "Okay, I'm ready to try again." And on average, it takes about 7 to 10 times for a person to quit smoking for good. Now, I do know some people that were able to just quit cold turkey, and I applaud them. But that's not everybody. Nicotine is very addictive, and it's hard. So, almost every state has a quit line that you can either, if you don't want to see a coach, you can enroll into the quit line. They even have apps that you can use depending on what state you're in that can help you, quit smoking, get the products. They check on you. They make sure it's working for you. You can let them know if you're having any adverse side effects or whatever. So it really is important. And of course, we know smoking is really a contributor to a lot of different cancers, a lot of different cancers. So, and healthy lifestyle, cardiovascular wise, diabetes. I mean, smoking can cause a lot of different things and exacerbate a lot of different diagnoses. So it's important to stop.
Yeah, absolutely. Here at Collaborative Cancer Care, so we see cancer patient survivors and family members for, mental health services. And we have patients who have lung cancer, they have a diagnosis who are still smoking. And
Mm-hmm.
I think, one thing we have to really talk about is the stigma there.
Yes.
Like we said, smoking is an addiction. It's not something that you just start and stop
Mm-hmm.
cold turkey. That's why this program exists. But we also refer patients who have cancer, who are currently smokers, to these type of programs for smoking cessation. But I would also say, because it's a psychological thing too. So even if you are enrolled in some sort of smoking cessation program, I would also advise that you are in some sort of counseling, so you're not doing it alone.
That was going to be my next thing, behavior modification. You
Mhm.
need support. Absolutely. Yes.
Yeah, yeah. And for our patients out there who have lung cancer, who are smoking, it's okay.
Hmm.
It's a process. You didn't develop the habit overnight. People may judge you or say X, Y, or Z, but there's help out there, and we are here to really support you through that. So I just want those individuals to not feel judged, and that we understand that it's a habit and it takes time. It takes
Absolutely. Absolutely. I've met quite a few patients that are, said to me, I feel like I caused this on myself.
time. Hmm.
And so why should I quit now? Because I've already done it to myself. And I try to explain to them that, okay, you're smoking now, but if I can get you to quit, your treatment is going to be so much more effective. You're going to have a better outcome, a better quality of life. Don't don't judge yourself so hard. It is an addiction. And a lot of people don't equate cigarette smoking with an addiction. When they think of addiction, they think of alcohol, they think of drugs, gambling. But cigarette smoking and tobacco smoking or chewing or whatever you may do is an addiction. Even vaping, that's an addiction. It's nicotine. It's the nicotine that's the addiction.
Yeah, absolutely, absolutely. So, Trina, what you're doing is tremendous, and I just truly believe every, oncology office, organization, hospital
Yeah,
should definitely have this.
yeah.
So, what can people do to really implement a program like this into their organization? And I'm saying that knowing that there is a shortage, right? A nursing shortage, healthcare shortage.
Yes,
However, we still have to do the work. We
we
still
do.
have to, be there and provide the best care, for our patients and communities.
Mhm.
So, what is something they can do to really implement, maybe even a portion of this type of program?
A lot of the oncologists would before just talk to the patients whether or not they would quit smoking. The phone your visit is only maybe 30 minutes if you're a new patient, and then 15 minutes if you're a follow up. So you have so many things that you're going over with this patient. There's so many things that you need to discuss and make sure the patient understands and their family that they'll say, okay, you want to quit smoking, I think it's important, here's a pamphlet. And the patient, 9 times out of 10, they're so overwhelmed with everything going on, they're not going to follow through themselves. So the one thing I liked about my program at the Cancer Institute was that they had me there, and I was their go-to, and they could refer the patients to me, and then I would reach out to them. I'd give them a day or two to just digest everything, and they would give them my information, but then I would reach out to them too. So it's so important to have someone that can do to reach out to them to see if they're ready to quit. If they're not ready to quit, to follow back up with them again, because like I said, their treatment is much more optimal. It's important to have people in place that can kind of help the patients. So for me, I took the onus off the patient. If they said they were ready to quit, I did the calling of the provider to get the nicotine replacement product. I made sure that they were enrolled into the quit line. There was no issues. I called the pharmacy to make sure the pharmacy had the prescription and that the patient could pick it up. And I was like the go-to person in between. So that's important to have, like someone that if they can't be dedicated 100% of the time, at least a group of people or some people that can work with these patients that, okay, you're ready to quit. Let me move you to this nurse, or let me move you to this CNA or this medical assistant that can call and make sure the patients have everything they need once the doctor puts the order in. So it's just getting the program together and figuring out what your algorithm is going to be and how you're going to have it flow, and having someone who can take the lead, which will be important, and it kind of takes the onus off the providers because they have so much going on. But we want to make sure the patients have all the resources they need. So for me, it was very smart to have a navigator that could do this. It was very smart.
Yeah, I love that. And I see you kind of working with primary care offices.
Mhm.
So,
Absolutely.
those providers, they see
Mhm.
patients in the community who
Mhm.
may, be a smoker, may have a family history, maybe
Mhm.
coming back with symptoms of GI, for that screening.
Yeah.
But I also see oncology for the
Mhm.
patients that, we see here in the office who may have a diagnosis of lung cancer or have a diagnosis of breast cancer or colon cancer and still smoking.
Mhm.
So I think it would be ideal to, like, bring someone like you into an organization, maybe as a consultant to help
Absolutely.
maybe even develop the program,
Yeah,
maybe put
develop
things
them.
in
I'll let
place.
you know what the pitfalls are.
Yeah,
Because
yeah,
I've been
absolutely.
in the ground up. I did this from the beginning, so I know what worked and I know what didn't work, and
Yeah,
it's very important. Yeah, I even
yeah.
worked with surgical offices for patients that were getting total knees or hips or whatever.
Mhm.
They have to quit smoking. So they refer their patients to me. So it's been really good to be able to be the person that they could go to and get these patients where they needed to be.
Yeah, absolutely. So I love that. So if there, are organizations listening in, how would they get in contact with you to really talk about how they would start this program, how they may partner with you and your team to bring you in to really start a program?
Yeah, so I am actually starting a health coaching and consulting business, and I'll definitely that's going to be a part of it. It's going to be making sure helping companies that can start a tobacco cessation program if they have a something where they want to consult with me, and I can help with them and get their patients through. I want to. It's definitely important, and I'm really excited about it because it's going to be where I can help a lot of people, and it's not just one area. I want to be able to offer my services to multiple organizations and just kind of give them kind of like a blueprint of how to do it. Depending on it doesn't matter if you have a small office or a big office. There's ways to get around this and to get this done. So right now I'm still kind of like getting everything together, but my email for them to call me and talk to me. I definitely would consult with different organizations or different groups that want to do tobacco cessation. I am through Delaware Quit Line, and I am Mayo certified. So probably my best thing is probably my email right now.
Okay, and we can put that at the bottom
Oh,
of this video so people can definitely connect with you. So
absolutely,
this
absolutely.
has been a wonderful session, and there have been so many nuggets, but I want to try to wrap it up and give
Okay,
people some pointers. So I'm gonna jump in, and then you jump in and fill in where I didn't. So the first thing is one, knowing your body,
amen.
knowing when you need to consult your PCP.
Hmm.
The second thing is being an advocate. So seeing a PCP and really advocating for what you need or what you think is going on.
Yeah.
The third thing is knowing your family history
Mm,
is so important
so important.
even before
Mhm,
you are, developing symptoms.
mhm.
The fourth thing is really understanding that in life we develop habits such as smoking, such as overeating, all these different things, and
Absolutely.
that there is help out there. Don't allow people to judge you or put you off just because you are doing something. You are you developed a habit
Right.
that can be detrimental to your health, and that there's help. We're here to help you. Dr. Trina Turner is here to help you.
Absolutely.
So is there anything that I did not touch on that you would like to say?
Just, especially for my patients that have developed cancer already, the stigma is so bad. Don't beat yourself up. There's help. If we can get you the help that you need, and you will have a better outcome. If your treatment will be much more effective if we can just allow us to help you. Don't beat yourself up so bad that you're like, okay, well, it doesn't matter. I already have it now. Whatever, I'm done. It doesn't matter. Don't give up on yourself. Don't give up on yourself. Let us help you. Definitely.
Yeah, and I would say this to our cancer patients, not just lung, but cancer patients who are currently smoking.
Mhm.
Ask your oncologist, ask your nurse practitioner, ask your oncology infusion nurse. Is there a smoking cessation program that they can refer you to? Because
Mhm.
many times there are programs out there that they can refer you to. And what I would say to our healthcare professionals who are watching, if you have patients who are smokers who's getting treatment, for cancer,
Mhm.
offer them the program because many people they just don't know. We don't know what we don't know. So
Exactly.
I think it's onus on the patient and healthcare professionals to really provide this resource for patients.
And honestly, our cancer center developed kind of like a little informational, educational, patient-facing education piece that they gave them a pamphlet, and they had my phone number and my name and all that on there. And they gave it to them during their first visit. If they're still smoking when they came back for their follow-up visit, they gave it to them again. And you'd be surprised how many patients called me later on and like, okay, you know what, I'm ready, because they have to be ready. No matter how much I talk to them, no matter how much I stress on them the importance of quitting, their mind has to be there and they have to be ready. And I've had so many patients just having that pamphlet and having that resource allowed them to get themselves together, get settled, and know that this is what I need to do. And then they reached out to me. I had a lot of patients that do that. They reach out to me later on when they're ready. So just making sure they have those resources too.
Yeah, absolutely. That's really true. It's when they're ready, but providing them the information is essential. And that's something we can do because, right now, our healthcare system, all these, insurance companies mandate that we assess people's,
Absolutely.
social history. Are they drinking? Are they smoking? And that's such a great opportunity to provide them with the information. So when they're ready, they can call and take the steps. So
Exactly.
that's amazing. But Dr. Trina, thank you so much for being here.
So
Really
Wendy, I
appreciate
love
it.
talking to you, and anything I can do to help with anyone that wants to start the a tobacco cessation program or screening program, please feel free to reach out to me. I have five and a half, 6 years of doing this, and it's really beneficial for our patients. And every cancer institute, every cancer continuum care should have this. So,
Absolutely. Totally agree with you. Well, thank you so much, Trina, and we'll definitely have you back.
okay, thank you. Nice seeing you.
You too.